And we are starting. Here we go. Welcome, welcome to the workshop, setting up your meeting for Facebook Live. Okay. All right. Great. We are streaming. Excellent. We are going to let everybody in, admit all. Welcome, welcome. Hello, hello, everybody, and welcome. Good job. You're all on time. Thank you. Hi, Nava. Hi. Hi, Adina. I'm very, very excited to start soon. We'll give everyone a minute to join. In the meantime, I'm going to give you a little introduction for those of you who don't know who I am. I'm Dr. Lilach Saperstein. I am an audiologist and host of the All About Audiology podcast. If you haven't heard the podcast, I am so excited to let you know about it because we just had 50 episodes. So there's a lot to go back and see and pick whatever topics you're interested in, or you can search in the keywords at allaboutaudiology.com or anywhere you get your podcasts, and you can find lots of information about audiology. And today we're going to be talking all about ear infections. That is the topic. Hi, Marlea. Thank you for turning on your video. It's always nice to see who I'm talking to. So I'm going to share my screen in just a moment, and I want you to know that at any point you can put things in the chat, and if you have questions along the way, that is good. I'm assuming you all hear me well because you're looking calm and relaxed, so we're doing okay. Let us begin. Here we go. What do you think about when you hear ear infections? This is the first question I have for all of you. When you hear about ear infections, there's a lot of different associations that comes with that. You might think of little babies and little toddlers like crying and being really unhappy and sick. What else comes to mind? Doctor's visits. Feel free to put in the chat as well. Actually,
yeah, I work with young children, so when I hear ear infections, I think, oh, these things are the worst because
6 months and there's still questions, but let's go. So, ear infections. We're going to be talking today about the ear because that's where you have to start. You have to start with the ear to understand anything about audiology, basically. And I think it's very important for us to kind of go back to the basics and see what is the structures and the pathway of how we hear. And then that answers so many questions that we have about these topics. So what we have here is a colorful picture for the colorful people and a black and white picture for people who prefer it, in starker detail. So pick whichever one you like looking at. So we start with the outer ear, and that's, our ear, what we call the outside. That's the pinna, and that is collecting all the sounds in our environment that are coming in around us and going into our ear canal. That ear canal has wax, it has all these sweat glands and things that keep that area just kind of lubricated with the kind of waxes that it needs to have to keep it safe and clean, that no bugs should set up home in there. It's supposed to have wax. And that's something that a lot of people want to know and ask audiologists, should I be using Q-tips? And the answer is no, do not use Q-tips because it just pushes it in deeper and it's also introducing bacteria to the ear canal. It's just not a good idea. Just let it do its thing. And if it does accumulate and become a problem, then you should really try and see a ENT doctor or even a primary care doctor can help you take it out safely. And please never pins. Pins are the worst. Anyway, that was just a tangent on here, the outer ear, because that's the first station. This ear and the ear canal is the outer ear. And then we have the middle ear. I'm going to point to it here. It's like this pink section here. Over here, it's this little, kind of looks like a little pocket or a little house. you could think of it. And this middle ear is the star of today's topic. The middle ear does a lot of important things. And it has the tiniest little bones in our whole body, these 3 little bones, the hammer, the incus, and the stapes. And what these 3 little guys do, one pushes the next one, who pushes the next one, who pushes the next, and they make a chain of little bones that pass the sound that comes in, hits the eardrum, which is right here at the end of the ear canal. You have your eardrum. Then right behind it, there's these 3 bones that move that sound along. They conduct the sound. They move it along this pathway. And then they bring it into the inner ear. That's the 3rd section. The outer ear, the middle ear, and the inner ear. The inner ear here is the cochlea. And the cochlea is filled with fluid. It's got tiny little hair cells that move when the sound goes through them. It also over here with these canals that kind of go like this. One goes this way, that way. That is our balance system and helps us orient in space and keep our balance and keep our head straight and all the things that our balance system does for us. So all of that is in the inner ear, and that is also a whole other lecture series. But today we come back to the middle ear because that's the place where those infections like to live. So in a healthy, normal, wonderful ear, the middle ear space is clear and aerated. It's just empty and full of air. So there's nothing else there. Oh, I'm just letting everyone in who's joining. I'm so excited to have you. Welcome, welcome. Okay, so we have, but then when I do that, I can't see you anymore. There you are. Okay, so welcome to everyone who's joined. We are in the middle of talking about the anatomy of our ear, the outer ear, middle ear, inner ear. We're coming back to the middle ear, the star of today's conversation. And we'll do another mini introduction in a while. But what we know about the middle ear space is that it needs to be full of air, and it does something very important for us. Look at that. I like starting on time, but you guys can come whenever you like. I'm happy to have you. Welcome, welcome. Okay, and thank you all for muting yourselves, but later on when we have questions, we'll definitely open that up. And again, if you want to type anything in the chat, go ahead at any point. So we're just doing this brief overview of the ear anatomy, and the middle ear space needs to be filled with air. How come? Why does it have to be like that? Because the middle ear does something important. It keeps the pressure, it equalizes the pressure over here between this space and outside the body, the rest of air pressure in the air, in the environment. And how does it do that? With this very special tube right here, this canal that's inside, that is called the eustachian tube. And the eustachian tube is what connects the ear, the middle ear specifically, to the nose and the throat. That's why you have specialists who study and become ENT doctors, ear, nose, and throat, or otolaryngologists. And what this whole system is an awareness of how our brain, faces our structure of our head, is that our ear, nose, and our throat are like one continuous system that all connect in the back of the nose, the back of the throat. That is called the nasopharynx. Also, I always laugh about that anytime you want the official anatomy terms, then it helps you just to know where you are. So naso is nasal is the back of your nose, and then pharynx is the back of the throat. So nasopharynx, and you just kind of translate the pieces once you know them, and that helps you know where you are. And so the connection of the back of nose, back of throat, and ear is right through this tube. And you can see it here as well in this picture. This is an important point right here. In this picture, they do it open. They're kind of showing it to you like a slide, like a tunnel, like a straw, a tube. And here it's showing it in a different state where the eustachian tube is actually collapsed and closed, and a little more of the nasopharynx back there. And what you see is that actually that's a little bit more accurate to how it functions in our head, in our face. That the eustachian tube usually is closed, and then it opens whenever we sneeze or cough, or even some people can do it on their own, voluntarily. You could just kind of open your ears, and that's the feeling that you might have when you chew gum, or when you're on an airplane or a roller coaster, or up and down hills in a hilly place where you're changing your the air pressure that's around you because of how high you are. Now I can't remember that word, latitude, how high away from sea level you are. So you have big changes in air pressure around you. And so the eustachian tube is doing its job of keeping that middle airspace, the middle ear that's full of air, keeping it aerated, keeping the pressures equal, keeping everything, working well. And that eustachian tube is doing a big job. So here we have it. This is the most important thing that I want everyone to take away from this, is that the relationship of ear infections and fluid in the middle ear and all the things we're gonna talk about comes back to this eustachian tube and how important it is for the function of our middle ear. Now, why do we want the middle ear to be full of air and not, what if it fills up with fluid? What if it fills up with other gunky things? Well, that is a big problem. Let's see what happens when it's not functioning in its ideal state. Okay, and also, again, I just want to see, because I don't see my chat when I'm sharing. So can someone just type something and then I'll see where it goes before we continue? Where is my chat? Ah, chat. Look at that. Found it. Thank you, Miriam. Hi. Thank you for the test. Got it. Okay, so now when you type something, hopefully I'll be able to see it. Except now it went away again. Whatever, we'll find it. Anyway, this eustachian tube that connects the ear, nose, and throat is different in adults and in children. And there's two major differences. We're gonna start with this picture up here. And when you see this picture, what do you see that's different? You can see that the baby's head, right here, this eustachian tube leading from their middle ear to their nose, is a lot flatter. The angle is much more horizontal. And then when you look at the adults, the whole head grows, everything changes as we age, as we grow from baby to toddler to kid. So you can see that the angle is very different. And a lot of people kind of just know this, this little tidbit and hold on to that as the whole answer, as the whole story. It's not just the angle. We also have to know this second piece of what is the difference between babies and adults. And that is this whole natural development and strengthening of the muscles that surround the eustachian tube and that are actually the ones that are making that opening and closing of the tube when it needs to open and close. And for kids, it's actually just kind of a flat, floppy, underdeveloped, well, not under because it's, just maturationally, developmentally, the baby's muscles are not as strong or developed to be able to do what adult size heads and musculature can do. Okay, so there's the two elements here, not just the angle, which it is, part of it is the angle, yes, and it does grow. As we grow, it becomes more of an angle. But the second piece there is about the musculature, okay? And when you think about it, babies are born, their whole motor functional development when they're born is to optimize sucking, to optimize for nursing, for breastfeeding or bottle feeding. That's that's the one function they really need to do. And so there's a lot of this kind of the musculature in that whole area of the back of the throat and the mouth, the back of the palate, all those areas change over time, over the first 12 months in a very rapid way, first 2 years, when the child goes from exclusively being in a sucking motion to then learning also how to chew and learning also how to swallow in different ways than the whole mechanism of sucking and swallowing. It now changes and there's different development of those muscles over the first year, year and a half, 2 years of life. And that then affects the development of these muscles that are around the eustachian tube. Okay, I'm talking a lot, giving you a lot of anatomy lesson over here. Is everybody with me? Any questions, feel free to stop me, drop it in the chat, etc. Okay, so what we see here is a normal middle ear. You've got the eardrum, the three bones. They look like they're all hanging out in space. They're kind of suspended there with muscles and ligaments that hold them in place so that they can do their conducting job. They're moving the sound along. And that is part of how we hear. If somebody, let's forget about ear infections, let's forget about middle ear fluid for just a second and just go back to, what else can go wrong in the middle ear space? What other things do we see? Let's say somebody doesn't have those bones. Maybe they're born without an ear canal, or the ear canal is closed. Basically anything from the outer ear and the ear canal and the middle ear up till there is what we call conductive hearing. It's the sounds coming from the environment and coming into the ear. This portion of our hearing is called conductive. It's getting the sounds in. And then once they get to the cochlea and the nerve endings and go up to our nerve and our brain, that part of the hearing is called sensory neural. And the sensory neural hearing is kind of the second piece of this pathway. We have conductive hearing and then the sensory neural hearing, and then it goes, if there's a problem, outer ear, middle ear, conductive hearing loss, and if there's an issue with the cochlea and the nerve and anything else going after that, then it would be sensory neural hearing loss. So other kinds of middle ear problems could be otosclerosis or anything that's keeping these bones from moving well. Like maybe they could be too stiff and then they're not moving. So what happens is, now back to our ear infection, is that if this space, instead of being filled with air and the bones moving freely, instead of that, we have a whole pool of gook, of mucus, and now they're like sluggish. They have to move through this gross, like just imagine putting glue all over this thing and like trying to wade through a pool of jello or something like that. So I don't know, the images help me. I don't know about you. That's how it helps me to visualize things. So when actually also in the UK, the term for like a very heavy ear infection is called glue ear. And I think that's a very apt description, where there's this heavy, gross, mucusy, gook that's hanging out in there. And not only is it not good to have that stuff there, then when it becomes infected, when you have bacteria that are like, ooh, warm, dark, liquidy, let's set up camp here, then you start to get inflammation. And that's when you see, look at this poor eardrum is bulging, it's red. This is a sick child, right? This is a kid that's crying, that's pulling on their ear, that's not sleeping well, that's not eating well. This is what we colloquially, like in regular terms, would call an ear infection, okay? But that's not the whole story. If that were, it would be like normal ear and ear infection. These are not the only two options. And that's where it gets a little bit more complicated and more important to really get more guidance and more specific instruction from your healthcare providers, your doctor, your pediatrician, your audiologist, to understand exactly what's going on with your child's ear or your patient. And that's also a good place to welcome everyone again, because a few more people came in as I was talking. And what I really value, and something I'm so proud of and excited about, the All About Audiology community, is that all of us come together from both sides, both parents who are trying to figure out how to help their children as best as they can, and also the professionals, the clinicians, who are also trying to do the best that they can for their patients, for the students they work with, and the families that they work with. And I think that dialogue and that connection is something that's really special, and we will talk more about that at the end as well. But back to ear infection. So sometimes I say your child, sometimes I say your patient. We're all talking about the kids that we care about, that we want them to do well. And adults get these kind of issues too, but ear infections is one of the most common things that will happen. I think there was a stat about it being that 75% of children will have some kind of ear infection before the age of 2, and that it accounts for some really high percentage of doctor visits and things like that. It's just extremely, extremely common. We're going to talk a little bit about the mechanism of why that happens. How does this occur? So here's another picture where in the top one, we see a middle ear. Again, let's orient. We have here our eardrum, bones, and this area that's supposed to be air, but hey, what's all this little liquidy stuff here? And this is fluid in this space, but not quite an infection, not quite infected. We call this otitis media with effusion, as opposed to this one down here, which is more of that glue ear. It's thick, it's gooky. You can't even see the bones anymore from how it looks. And this would be from looking in the ear otoscopy. We're going to have a couple of slides on that, what the eardrum looks like. So here you can see that it's like still a little translucent, which is what a regular eardrum looks kind of see-through. But here you can, it's still see-through, but you start to see this bubbling right here. And you can almost see the line, like the way that they did it here in the illustration. Like there's kind of this line of liquid up to here. And here you see the eardrum is bulging outwards. It's like you can't see through it at all. Okay, so these are some of the terms that you might come across. Of otitis media is inflammation. Itis is always inflammation. So the media would be the middle ear space. So otitis media, inflammation of the middle ear space, i.e. ear infection. And the middle ear effusion, this other word of effusion means that there has been some sort of moisture accumulation, let's call it that. So let's say, you know, sometimes if you're in like a damp basement or somewhere where like the walls feel a little wet or a little damp, that's because in the basement room, in this like space, there's uneven air pressure, and the air pressure in the room is actually pulling in, creating sort of a vacuum, a low pressure system inside of the room, and that's pulling the moisture from the walls. And that's almost exactly what's happening in the middle ear space. Now, our ears are smart. Our body knows what it's doing. Like there's these mechanisms in our body that are protecting us. And let's talk about what I mean about this. And then it just goes too far. And it's like keeping up this protective mechanism, but then it becomes harmful at a point. So what happens, let's go back to the middle ear space and the eustachian tube. And now this eustachian tube needs to open to let us get that equalization of air pressure from the air around us to the air inside that space. It needs to open so we can equalize that pressure. But what if it doesn't open? What if that eustachian tube is just closed, right? It's like a tube, right? So it's supposed to just open when you sneeze, when you cough, but it's staying shut tight. So what happens in the middle ear space is that it's the air pressure is like creating that vacuum, and it needs, if nothing would happen, then it would kind of collapse upon itself. The rooms of the room, that's why I kind of call it like a room. Even the wording is like there's the attic and there's the floor, and so that's like the visualization of a room really helps here. So if the low pressure system would maintain itself, it would just collapse. And then what would happen to those bones that are suspended very delicately by these super teeny tiny tendons and muscles? That whole area needs to maintain its conductive pathway. So what does it do? It starts to pull the moisture from all the mucus cells that surround it so that it is protecting its shape and protecting the middle ear space from collapsing upon itself. And it starts, you see from here, like if that tube, the tube that would be coming right down here, the eustachian tube, it's kind of like starting here, it's collecting at the bottom, and then it's accumulating more and more and more. And in that time, it would accumulate until there would be such a pressure from the actual fluid that's hanging out there that would be the opening, and that would cause this eustachian tube to actually let that out. And that could, again, just like happen on its own because of the pressure that's created now from the fluid. Or it might happen because you blow, like if you close your nose and blow and you kind of feel it go inward. I'm sorry if that's gross for some of you, but where you can experience it. You maybe have seen it in yourself, in your own head, in action, again, like in the roller coaster, in the airplane, where there's this popping, and it's painful because like the muscles are closed also for a reason, because that's also kind of protecting that. If it would always be open, you kind of like, do you ever remember being in a really cold day, like in a snowstorm, and you feel cold inside of your ears? Like there's such a thing where we actually want that eustachian tube to stay closed and protect us from like different temperatures, different air pressures. So again, our body is trying to do its best, and that accumulation of fluid is not necessarily bad. It's bad when it sticks around. And if it continues to just be there, then the bacteria can come and colonize it, and that's when we go and end up with an ear infection. So that's kind of mechanism number one of how we get, someone new is joining us, welcome, how we get from, airspace, healthy middle ear, to ear effusion, this kind of like dampness or fluid hanging out, and then the next stage would kind of be otitis media if that's not, if that doesn't resolve on its own or isn't treated. And okay, so that's number one, like this whole protective mechanism. And number two of how we can get to here, to ear infection, to otitis media, is through having a super disgusting infection in the nose, like having a mucus rhinitis, like gross upper respiratory infection. And, when your tissues are green or like yellow, like disgusting, it's already infected from somewhere else. Like the infection has started in the nose or in the throat, and then it goes up the eustachian tube and then has now migrated up the eustachian tube into the middle ear space. So you see how these two things are kind of different. And again, understanding what's happening here also then tells us what we need to do in terms of treatment, in terms of intervention, which we're getting to. Okay, and I also wanted to point out over here that you have this clinical guidelines from the Association of Otolaryngology in America, this big review paper that has a lot of the research if you want to dive into that. So what would be the difference between these two children, these two conditions, one with ear fluid and one with an ear infection? Ideas, thoughts? Because we talked about how did this happen, the two different ways, and who is this? What does this child look like in in professionalese report writing? We say the clinical picture, like how do they look when they come into clinic? But for parents, it's like, what does your 4 a.m. look like? Right? What is your kid doing? So there's very different behaviors that we would see with the ear fluid versus the ear infection. The child who's really experiencing this might also have a fever, might also be super cranky, again, won't want to eat, won't want to sleep well, like just lethargic, not into anything, whining, like a sick kid, not well. Do not send this kid to school when there's school in the world. But the other child, the child with ear fluid, might look just fine. Just walking around, happy kiddo, nothing's going on. And they're just maybe hearing things a little muffled, maybe not, because it kind of depends on how thick that fluid is. If it's super runny, like just watery, then it might be affecting them a little bit. If it's more of like a little more viscous, like, again, I don't want to gross you out, but pudding or mayo, like, are we going to that direction where it's like gelatinous? Or are we really going to that heavy, gooky, gross goo, right? So there's kind of this, what kind of ear fluid has accumulated there? So that child who has middle ear effusion might not show any symptoms whatsoever. And especially if they're super young, under 1, before we have more language development on the way, they might, not be able to even know or communicate or let you know in any way that they're uncomfortable. And they might not even know that they're uncomfortable because it's kind of like, oh, well, that's how I hear. That's how I experience my ears. And there isn't something to compare to because you're just born. You were born yesterday. So, even some infants, like super newborns, will have this fluid in their ear for a day or two or a week or something, because from the birth, just from the whole experience of living in water and then now living in air and now having a different, having to clear out all of that suctioning. That's what they do right when the baby's first born, is suction it out of the nose, suction it out of the throat. But some of it might kind of have gone up to the middle ear and still stay there. And we see that sometimes when we're doing the newborn hearing screening. And some babies won't pass the screening, and then the next day or a week later they will pass, and it wasn't because they have a hearing loss, it was because there may have been some fluid. However, again, side note over here is that we never want to just say, if someone doesn't pass, oh, it's just fluid, because you don't know that. That's the whole point of having a screening, is to actually screen and see, are children passing? This is a pass, or do we need to refer for more testing? So if someone doesn't pass, we still for sure want to get testing and repeat it. And then if they don't pass again, come back at a month and do a full evaluation and all of that, because it's super important to have early identification of anything that's going on, so we can help as early as possible. But anyway, ear fluid. The child with ear fluid or middle ear effusion might also have a very interesting behavioral story. And this we might see closer to the 1.5, 2 years, 3 years, the, walking around but young kid, toddler. And this toddler might have a inconsistent behavior. So like the classic picture is that, let's say they sit in a circle with a couple of kids in the library or at school or nursery school or whatever, if they're in a setting like that. And the teacher will say, for a week and a half or so, this kid is with it. He's sitting, he's singing the songs, clapping the hands, like following along all of our stuff. And then for the next day, all of a sudden they're in their own space. They're not paying attention. They don't turn around when they're called. And there's going to be this kind of switch where it sometimes they are attentive and sometimes they aren't attentive. Now, how much could you really know about a child at that age that's just constantly learning new things and going through so much? But sometimes it's so apparent that someone close to the child, the parent or the teacher, might say, I'm noticing that something is off, but I can't really put my finger on what. They're just not themselves, let's say, but they're like healthy, right? So this is an important distinction between these two pictures, okay? And that brings us also to, when should you worry? Okay, or worry in quotations, or when should you seek medical attention? And the important thing is that if a child is sick, they need medical attention. They should go to the doctor. But, we always have this worry of, am I being too overcautious? My husband is a family physician, so we do sometimes have this question, this conversation that comes up. Is the person who comes in every fourth day with something that's going on with their kid, are they just like super anxious about everything and want to know? Sometimes that's great. That's the right thing. And other times, you have parents that are just in general more laid back and will let things go. Anyway, we have a lot to talk about, and I'm excited to keep going. But I go on my tangents because I feel like we have to know how this matters. How does it look on your kid or in your classroom or in your Zoom room? Anyway, so let's talk about, what do we do? And yeah, Ellie, I see your question, and I'm just going to go through this and then open it for questions. Okay, so here are some of the things we can do. We have to realize that not every ear infection is really an infection. It could just be fluid. And if that's the case, it actually probably will resolve on its own. It will get better on its own over 2 weeks to 3 months. That's kind of the average. And in the study, they had a study of several, 400 kids or something like that. I'll have to look exactly. But it was something like, when they looked at all these different cases, the average was that it resolved in 17 days, without any treatment. They just watched it. And so that kind of gives us this right here, the natural course of things going on with the ear might be 17 days, a month, you want to call it, the season of when everyone is just snotty and disgusting, sorry, like coming into fall and winter. And it's just like, let's keep an eye on these kids, but we're not rushing to do the kind of treatments that we'll get to in a second. And there's expressions for this, watchful waiting or wait and see, which kind of give us a pause, a little break on getting super frantic about, what's going on with their ears. Are they going to be okay? And it kind of is just one of those things that kids go through when they're young. It's uncomfortable, but it's also building up the strength of their eustachian tube. It's kind of this whole cycle of the body finding its balance, finding its homeostasis, and getting, doing well with it. So we kind of like start there. And then when there are exceptions to this, like, no, actually, this is an infection, or actually, this is affecting their speech and language, or it is going to have long-term implications on their hearing, that's when we do the intervention. So I think that's like, again, one of the main points I want you to take away from today is that it really is case by case. And we want to see how everybody, what this child needs, as opposed to what do we do about ear infections for everybody all the time. Okay, so the second issue here is this piece about the hearing. Is the hearing affected? And the way to find out is to do a hearing test with an audiologist in a booth with methods that we, have ways of really getting information from children, from young children, starting at 6-7 months old. We can do testing where we play a sound in the room, and then there's also a light up toy over here, so that whenever the sound is played and they look over to see what's the sound, then they see this flashing toy and they get excited about it. Wow, cool. And so we do it a couple of times to condition that response, that every time they hear it and then they look, they get this kind of reward, reinforcement. And we're able to get very reliable, in many cases, results about how this child is hearing, even if it's in a gross way. We're not going to get it specific, minute, the way we can with an older child or an adult, but it definitely gives us information. And we do see, we can, from the audiogram, that's what this is called, the results of the hearing test, we can have more of an understanding. Is this affecting the hearing in a significant way, or are they kind of hearing just fine and we're going to keep watching them? And yeah, the role of audiologists is extremely important in getting these kind of baseline test, and then a follow-up a couple of weeks later to see if there was a change, like in 6 weeks or 2 months, to see where are we now? Has it changed, or is it the same? The first time we see a child is different than if we've seen them already 2 or 3 times and we have a history. Okay, now this here, number 3 of meeting the targets, and I realize I went this way, I don't know. Meeting the targets, is this child on target for basic speech and language milestones, like having first words by a year, like even mama, or for their bottle or something that is consistent over time. They make the same string of words, like even if they're saying baba for bottle, but they say that every time and they know it means bottle, and they don't say it about other items, right? So the definition of a word also is quite open. We just want to know if there's some that we're kind of reaching those targets, and if they're not, right? And then by 18 months, we want to see some 2 words together and things like that. So, and again, I defer to my speech and language colleagues because that is their exact specialty. But if we're seeing that there's also a speech and language delay, this is a case or child that we would maybe flag or say, let's do watchful waiting for a shorter period of time, because already we're seeing there's some kind of impact here. And we want a child with a speech and language delay to have as good access to the sounds around them as they can, right? And we would say maybe differently if there wasn't a speech and language delay. We kind of are balancing all these different factors in order to make a recommendation. And again, this monitoring, really keeping an eye that the watchful waiting period does not become, I'll see you next spring, and that's like 16 months later. No, if you're going to do the watchful waiting, you know, you have to see if this is the kind of family and the kind of community that has resources as well to accommodate this kind of serial monitoring. Because if you can only get an appointment every 6 months, then that appointment is going to look different than a healthcare system where someone can, let's say, come in once and then come in 6 weeks later and 6 weeks after that, right? Different things to keep in mind. I know we have a big international audience here today and for the podcast, so I always try to keep those things in mind, that every country and region and location will have different access to healthcare and access to this kind of, you know, that it should be more reliable. And then you have to make your recommendations based on what's the real world situation of the family. I remember speaking to an educator in Hawaii who told me that most of the families she works with have to fly from their island to the main island for the hospital, and that is obviously expensive, obviously days off work. Not everyone can do that. And yeah, that the local situation where she was extremely different than, you know, someone who lives in a major city and has 7 hospitals that they could make appointments at. Anyway, let's move on. Actually, yeah, Ellie, I'm happy to take your question now if it's not about intervention, because that's coming, but for everything we've talked about so far. And you could unmute yourself or type if you choose.
I'll wait. I'm still.
If you're still around, let me know. Or if anyone else has a question, now's kind of a good time to pause. Anyone? Otherwise, I keep going. Okay. So I just wanted to talk a little bit more about what the testing looks like in the clinic here. So one of the things we want to do is see the eardrum, and pediatricians, ENTs, audiologists can do otoscopy. Actually, that does differ across countries as well, of how much audiologists actually also use the otoscope, less in some countries than others. But nevertheless, the otoscope is this light with this thing called a speculum that we put on. So that changes for every person. We don't have them all going into from ear to ear, right? That's like either gets sanitized or disposed, just because we're all a little obsessed with infection control at the moment. It is 2020, what should I say? So what does the otoscope let us do? It lets us be able to see and visualize the eardrum. And remember, back to those pictures, that gives us a lot of information, because a healthy, beautiful eardrum will be kind of see-through. We'll even be able to see some of the bones through it, depending on how much, but you can really see outlines or even more clear the bones that are there behind, especially the first one, the malleus. And we want to see the color of it. We want to see also just in general how the ear canal is looking, the eardrum. So otoscopy is very, very important. OTO is ear, like otolaryngologist. And then the second tool that we have is this tympanometry. Tympanometer is a device that can shoot out air pressure and also take it back. Kind of like has a air pressure valve that it can put in air pressure and take air pressure out at the same time that it's also measuring other things. And so this whole system right here is able to tell us how it is the eardrum moving. What is the movement, mobility of this eardrum? And what we actually do during this test is we create a vacuum, take some of the air pressure, and then put some air pressure back in like a negative, then positive way. You can feel it when they do this test. It kind of feels like a little whooshing. It's not totally uncomfortable. It's fine. If you're worried about the kids, they're fine. They might not like it, but it's not painful in any way. And this one right here would be the normal result, which is that when we take air pressure out, the eardrum gets sucked out. And when we put air pressure in, the eardrum gets pushed in. And so it kind of has that roundedness that it can go in and out. And that would be a type A, typical, beautiful eardrum that's responding beautifully. What happens if behind the eardrum is all this fluid and gook no matter how much pressure I'm putting in here, that eardrum is not moving and it's just staying still. When you put air pressure in, when you put air pressure out, it's just stuck. It's not moving. And that would be a flat. We would see no movement. And there's different things like more negative pressure. So it's like a little bit, we're seeing a problem with the air pressure equalization, or maybe the eardrum is like super floppy and is doing one of these. But again, too many details, just to give the overview of what we're doing in clinic. What are we getting? What information can we see? Not only to see the eardrum and like see, is it red? Does it have a hole? Is it red and bulging? And then also to get an objective measure, not only for what we see, but also to actually measure how is it moving. And there's a tool that combines both of these things called pneumatic otoscopy, which is basically otoscopy, looking with the light, at the same time as putting in air with this little bulb. It's right, you know, this little, bulb. Okay, so it's pushing in the air. And this usually, ENTs would be doing this mostly, because what they're doing is they are looking at the eardrum at the same time that they are looking for the movement. So the tympanometry that we did before gives us a objective measure, like from the equipment reading out how much was their movement and change in the air pressure. So that's more of an objective measure. And this would be with the doctor looking in and seeing for themselves, like with their own eyes, what kind of movement are we seeing? And maybe in these illustrations, you might be able to see a little bit that kind of pulling out and then pushing in. Again, that like movement. And then this one isn't moving at all. It's just stuck. And so that's an overview again of this term. And you might see the doctor doing this to your kid, and they're probably going to be crying while they do it, but it's not painful. It's just like bursts of little bit of air, like to see how the eardrum is moving. Okay, so that's where we are until now. Again, any questions, let me know. Now, what are the medical treatments that we see when you come to the doctor, the pediatrician, or the ENT? What's going to be on the table? Historically, until now, and hopefully less and less over time, antibiotics was handed pretty much to everybody, ear infection, antibiotics. And that is actually not recommended anymore. Again, you can see back in that paper where they go through lots and lots and lots of studies and then bring out the clinical guidelines and recommendations. Antibiotics are actually recommended against giving antibiotics when there's an ear infection, because of the idea that this is something that kind of comes and then resolves. And it comes and it hangs around for a bit. And if it doesn't have so many other factors and implications, then we can kind of just ride it out and see that the child is able to overcome it. And doing the antibiotics, doesn't seem to actually make that cycle go faster, and B, makes resistance and issues with the effectiveness of antibiotics overall for other things that are more crucial for the health of this child and of society in general. So the recommendation to give antibiotics has been definitely counseled against in general. And so you do see this a lot less. Of course, that is the medical opinion of the physician, and they will see their clinical picture. Again, depending on what else is going on. Do they have some other infection as well? And then they're just kind of throwing antibiotics at that. But if you know the old joke, if I give you the antibiotics, it will get better in a week. And if I don't give you the antibiotics, it will get better in 7 days. So was it really the antibiotics? I don't know. And it's, again, the kind of thing you can't know when you're in the moment with a child in the office, but you could kind of know that a week later. Nasal sprays is one of the things that also has been kind of offered at different times. And again, it seems that if the ear infection or the otitis media or fluid in the ear is the issue without other nasal issues, it's actually not making such a difference. And those recommendations also counsel a little bit with caution about the nasal spray, like not totally recommending or saying, yeah, this is the way to go. It's actually kind of like ease off on the nasal spray because it's not really making that big of a difference. And it's just poor kid, why should they go through that if it's not even helping? So, and other times if there's other nasal issues in the nose, then a nasal spray would be recommended for that. But if it's just an ear infection, the connection there is not as strong. And then we kind of have this like the big guns, which is this the surgery of getting tubes, grommets, ear tubes, buttons. They're called all different things. But basically, in this procedure that takes about 15 minutes, like it's not a complicated or very intensely invasive procedure. It's just to the level of the eardrum. And what happens is that the ENT surgeon will make a tiny little incision, a very small little space hole line in the eardrum, and place one of these little plastic tubes. They come in different sizes and different colors and different lengths. Some are longer, some are shorter, some have these little nubs so that they kind of stay in place. And you can see also in the illustration that the goal, what we're trying to do here, is to clear out that gunk because it can't go through the eustachian tube. That doesn't seem to be working. So we're kind of going to give it an escape valve to come out through the ear canal, like make a hole in the eardrum to let it out. And sometimes this is an excellent option, especially when you're at the stage of the super bulging. And if you don't do that, then that eardrum is going to burst on its own, and that's going to cause more damage. So sometimes the ear tube is actually a very good solution. And then that just helps with the venting and keeping the air pressure, the airflow. And those tubes usually come out on their own, and the eardrum heals on its own. And it seems to be, a pretty good thing. But then what happened is that sometimes tube surgery is over applied, and every kid with fluid all of a sudden is getting tubes. So it's like all of these things, again, have to be for each child, for each family. Like, what is also the history of the family? Some families, they know, like they have 4 children and all 4 of them had tubes at age 3 because of these issues. And all of them had speech delays, and all of them had recurring ear infections, that they had audiograms that brought their hearing down 50 dB. Like, that's children who need tube surgery. But this depends also on the doctor. Some doctors are more surgery gung-ho and want to just put tubes in every ear, and other doctors are more conservative and want to play the wait and see game. So it also depends on what kind of doctor you're dealing with. So I hope that this helps a little bit of an overview about what the medical treatment is going to be. And here we are getting to the prevention, which is something that I think we all really care about and want to do the best that we can for our kids at all times. And here are some of the things that do seem to have the biggest impact, more than all the other things, that we've talked about, is to try to avoid getting to the situation in the first place. So drinking while lying down is one of the big ones. And that goes back to the, things coming upwards from the nose or from the back of the throat up the eustachian tube. And if you're lying down drinking, you actually cause the eustachian tube to open. And that's actually, if that's happening all the time, like this baby here, and is drinking all the time, then that could lead to fluid living in the middle ear space. And so it's a good idea to kind of have that 45-degree angle as much as possible when drinking. And so sometimes we see that, the first appointment, they'll come in with this, we'll give that recommendation, then they change that, and then it goes away. So is it because it just would have resolved on its own, or because of the pressure of drinking while lying down? It's one of those things that it can't be harmful, so we should try that. And even just do for yourself, like take one time a bottle and try drinking while you're lying down. It like feels weird. That's not the way that our whole system is designed, And the second one, that's like the big one that really, if there's anything that we can help as for so many health implications for children, is not to smoke around children, and, not even right near with them, but in the space where they live. So to leave the living space, to go outside of the home, outside of the car, definitely not to be close to children when they're smoking, because that really can and does affect the whole mucus system and how much mucus they are producing. Okay, and this picture I thought was giving us a big correlation that if someone is smoking, then it's very likely that the child will also then develop all sorts of respiratory issues of breathing and things like that. So this one is definitely like one of those things we know, we have the research, we know about the relationship of smoking and chronic ear infections. Ravita asked a question about adenoids. And that's another great question because, that's why the ENTs, it's so important to have an ENT that you trust and that that they can see the entire medical picture. Because as an audiologist, I am looking at the ears, I'm looking at the development of auditory skills and speech and language. That's like my focus. But if there's adenoid things going on, then again, I defer to the ENT for what they're going to recommend. And if there's other ENT issues like adenoid and things like that, then it might be related and it might not. So actually, sometimes they do the removal at the same time, and sometimes they do only a partial removal. There's all these, it really depends more on the surgeon and what the clinical picture, again, like what's going on with this kid, that would determine if the adenoids would be removed. But lots of times it's just a tube surgery. And again, it's a very quick in and out kind of thing. And not to minimize that it's scary and nobody's sending their kid to surgery for fun, especially not with general anesthesia. Of course, it's a big decision, right? But we look at the pros and cons and risks and benefits of everything about your family, and why I think, again, that this whole relationship of having professionals and parents together is important for all of these conversations, to not just be one-sided of like, here's what we're going to do, this is the recommendation, you should listen. But you're the parent and it's your kid, it's your decision. And Miriam asked about nursing while lying down, which I would think that and now this is just me thinking and going with you, that it would be the same. However, because the nature of nursing is very different than the nature of bottle feeding, even with all the fancy schmancy bottles that have all their suction flow mechanism stuff, like the fact is that if a baby is nursing, then there's a feedback loop between the baby and how much breast milk is being let down in conjunction to their sucking. So there's, I think, a lot less of the possibility of kind of the milk just coming in the way that it can from a bottle, without, the active sucking of the baby. So I think there might be less, but again, that's kind of just like my thoughts on it. These are some other prevention. I hope that answers your question, Miriam and Ravid. These are some other prevention strategies that are like, if you are here in 2020, that we are hand washing as much as possible. But in general, just to try and keep as little germs around the baby as possible, and avoiding putting objects in your mouth that were on the floor, and also getting vaccinations to keep baby in general healthy from other preventable diseases. And the pacifier usage is, again, this thing about like the sucking. When you sometimes see the 2-year-olds and even the 2.5-year-olds and the 3-year-olds with their pacifiers, not only is it affecting their dental development and their speech and language development, it's also limiting the motor functional development of the muscles of their mouth, their cheeks, their jaw, all the things that we want to kind of bring them into the next stage of their toddlerhood and childhood. It's actually leaving them in like strengthening the muscles for sucking, as opposed to moving on to chewing and talking and doing the other things we do with this whole musculature. So that's also a big recommendation. And breastfeeding when possible, because there have also been some studies about the correlation to breastfeeding in early months of infancy to less chronic ear infections as toddlers. And I don't know why I wrote vaccination twice. That's a mistake. Okay. So here's where we come to the long-term implications. We're playing this game, this balancing act between not wanting to rush to do things that are not good, like giving too much antibiotics or running into surgery when it's something that would resolve on its own. But the other side of this is that we actually do want to avoid the long-term bad implications that will come if it goes untreated. So we're always kind of playing this game to see what are our factors in this child's case and what's going to be the right course of action from there. So here are some long-term implications of ongoing chronic untreated middle ear issues, ear infections. I'm going to start over here with this speech and language delay because this is something that, you know, it's almost like now that we've had this whole conversation, of course, hearing underwater and hearing through gook would then lead to issues with your development of speech and language. But some people actually don't make the connection when it's actually happening to them. When we're in, you know, early childhood, you're running around, you're especially in the super beginning, postpartum. And this year, Corona babies, I've heard of that term, which is, you know, the babies that are basically home and not getting maybe to every single appointment and not having this extended family situation of being exposed to lots of different people and learning, building their immunity for like the regular early childhood stuff. Anyway, so there is definitely a connection, and we want to prevent that, avoid that as much as we can if we know that there's something making the hearing loss that is preventable, but then if it happens, it's treatable. And if we watch it and make sure that it kind of resolves and keep an eye on it, then we can try and limit the amount of the delay. And here, we also have some very interesting studies about the children who have a history of early childhood, like 0 to 2 or 3, 0 to 3, during that critical period of language acquisition. So let's say they had a speech delay, but then, okay, they caught up at 4, 5, 6, 7. They're caught up to their peers. But then what we do have a correlation to is that when they're in school age, when they're 7 and 8 and 9, they sometimes might show up with things that their auditory system didn't have the same level of skill and maturity that it would have if they were getting a crisp, clear signal to their hearing. And so there might be some issues with attention or behavior or auditory processing. And again, that's a whole other topic that we can talk about. But when there's something like chronic middle ear issues in early childhood, and then these other things show up, then, you know, you can make a connection. You can see how they would be related. Okay, and then this last one is really tough. This is the issue of what happens when the chronic middle ear really is not treated or is so chronic that it just keeps happening more and more and more and more. Actually, it can erode the bones, and so start to break down these little ossicles, the little bones in the middle ear, and that's now causing a permanent thing from something that was, you know, temporary, could have been treated maybe, and then if it wasn't treated, it could become permanent and then cause a conductive hearing loss that now cannot be treated or changed. Not only can it erode the bones, it can also kind of calcify and become fused to the bones that are around there. And if it gets really out of control, it can also start to go into the mastoid, which is the bone behind the ear, and then really do a lot of damage to the muscle, the skull, the bone, because the bones, excuse me, I'm tripping over my words a little bit here, but this right here is bone. And you see how there's all these little holes that are like aerated with air. And when there's a cholesteatoma, which is kind of this growth, calcification growth, it pretty much fills in all those holes and makes an infection of the bone. So, and then that needs to be surgically treated, and it's a tough one. So, you know, just to put this out there, that as much as we want to say, wait and see, and let's see if it gets better, until a point, because we definitely don't want to see any of this chronic implications for later on. Okay. And this is another, an audiogram, a way that we measure hearing and kind of put the test results. So I'm just going to run through this because this is something that, is very central to our audiology. If you've seen audiologists, you'll be getting their results on something like this on the audiogram. So it's helpful to see what this is. So across the top, we have the different frequencies. And we're testing just kind of like a piano from low frequencies up to high frequencies. And that's something, again, that, we don't just want to see people doing a hearing test that goes, Johnny, can you hear me from this room? And, whispering near them or shaking your fingers or all these things. Yes, they're going to tell you something about their level of hearing. But when we do an audiogram, we're getting results at different frequencies. We're breaking it down to each of the different sounds. And then when you go down this audiogram, that means we're making it louder. This is in decibels. So 10 decibels, 20, 30, 40, going down is getting louder and louder. And you have all these different pictures that are orienting you to what does this sound like. So like really soft rustling leaves is a mid-frequency sound. It's really quiet. It's around 5 dB. But a bird, which is also pretty quiet, like chirping in a tree, is the same level, let's say, but it's much higher pitched. So leaves would be more like, and then the bird would be like, okay, so that's how we have the high frequency. And now if you think of something super high frequency but really loud, you can think of a helicopter or a motorcycle that's like, zoom, zoom. Okay, you get me. I'm an audiologist. All right, but a jackhammer is also super, super loud, but it's more rumbling, low frequency, like a dog or a dripping. You get me. Okay, so I hope that's clear. If there's any questions, absolutely write them in. And then over here, this purple thing is actually called the speech banana because it's kind of in the shape of a banana. And they put in all of the different sounds. And this is really, really important for us to say, is the child being able to have access to all the different sounds of speech? Because let's say a child who has normal hearing will be able to hear everything from about 15 dB. That's normal. So right here in between 10 and 20. And then they'll hear everything that's below that well. They'll hear it well. All the sounds and people talking and clocks ticking and babies crying and piano and all the different things, they'll be able to hear it. But let's say a child has middle ear fusion and they only start hearing at 40. That means that they're not hearing anything soft whispered, and they're not hearing all of these soft sounds like t and f and th, sh, p, right? So all of these softer sounds they're not hearing because their hearing is only starting at 40 dB. And this is, something we sometimes explain to people is, oh, here's the audiogram. Your child has a 40 dB hearing loss where it should be up at 10 or 15. And they say, yeah, but it's only temporary. It's only because of the ear infection. And yes, it is only because of the ear infection. We can do that testing to be able to see where it's coming from in the ear. But if a child had a 40 dB hearing loss, they would get hearing aids. Like, we don't really want children walking around with a 40 dB hearing loss when they're trying to learn language and interact with their world in a hearing world. Right? So that's something we want to avoid and, keep an eye on, monitor, understand. So I hope this audiogram overview was helpful. Okay. Now, these are some of the risk factors. I'm not going to read all of them, but, again, if we're saying a child that's fully, has no other health concerns, had a typical birth, typical pregnancy, like basically no risk factors for a child, and they have an ear infection, that's one thing. But if we're looking at another child who already has other things, a craniofacial disorder or any syndrome or developmental delays that are global or anything else that's kind of, they're already dealing with, they're already facing the challenges of what's happening there, and then they get ear infections, that's putting them at further risk for the long-term negative implications that we talked about before, speech and language delays, and not letting this become a more permanent thing. So these are children that we'll want to keep an eye on more than, be more aggressive, you might say, in the treatment and in the monitoring. Definitely if a child has a permanent hearing loss in the sensory neural portion, sometimes it gets overlooked because we say, well, this child has a hearing loss and maybe does have hearing aids and maybe does get all their treatments for their permanent hearing loss, but then they might have this middle ear and conductive hearing loss on top of it that could be missed, right? So we want to watch those kids. Speech and language we talked about, autism spectrum disorder and hearing loss have a lot of overlapping symptoms for, you know, a child who's inattentive, a child who doesn't answer to their name, a child who doesn't necessarily interact or respond to verbal and auditory stimuli, right? So some of that, everything I just said, could be hearing loss and could sometimes show up in autism spectrum disorder. So we want to, again, keep an eye here and the rest of the list, including cleft palate also. There's, you know, a strong association with that. One note I want to say about trisomy 21, formerly known as Down syndrome, that actually I remember a story about a mother whose child had trisomy 21, and she said that for 6 or 10 months or something, a lot of times she went to visit with ENT, she went to visit with her doctor, she went visit after visit saying, my child has something going on with their middle ear, they're not hearing well, they're you know, what should we do? How do we treat this? And almost all of those interactions, the doctors were like, yeah, we know that it's very common in this population because of the craniofacial structures that are typical of children with Down syndrome or trisomy 21. And she was like, yeah, so if it's typical, then get me treatment. Then send me to, like, let's move more, not let's move less, because yeah, we know it's related. Anyway, that was just one of those things that sticks with you when you experience it. All right, I'm opening the floor to your questions before we talk about communication strategies, which is like the biggest thing we all want to know is what do we do when we're in that wait and see period? Because you don't want to just say, well, I'll wait and see, and in the meantime, they're not hearing you well. So how can you have really clear, effective communication at the same time as you're waiting? Or anyway, these are good advice for everybody, for all children, all the time, but all the more so when there's anything in the way. So these are also pictures from when I worked at St. Francis School for the Deaf in Brooklyn with some of the most delightful children I've ever met. We had so much fun. And, you know, we always had in mind these strategies as much as we can as they applied to each child's situation for how it would be best to speak with them. So we're going to talk first about limiting the distance. And again, in the year 2020, we're like distancing more and more and trying to keep 6 feet between everybody, but as much as you can in your own home and with your own children, to try and limit the distance and not talk from the other room or from the other floor and just think that you will be heard across 20 feet away. And to try and speak in a clear and natural way, facing the child so they can see your face as well. One of the biggest ones that comes up a lot is washing dishes. Like, why can't this is in adults mostly, but they say, why can't my spouse hear me when I'm washing the dishes and they're in the kitchen? And it's like, really, you're not facing them, and the water's running, and you're clinking all these loud things the whole time. Like, that is not a good communication situation. As much as you can, speak clearly and naturally, but be visible. And that also goes for having good lighting, right? And facing each other. And this also comes to play in the car. If you're the driving parent and the child is behind you, that is a more challenging situation. They're going to have a hard time to hear you when they can't see you. And you're also speaking forward so that, you know, that just the how much those sound waves have to travel inside of a moving loud car. And don't get me started if the radio is playing or a video, whatever. So anyway, let's keep those things in mind. We sometimes forget when we're just like living our real life, but it's important to take a pause and try to manage what we can. Which brings me to the next one, which is to get their attention, to say their name before you start talking. So if you say to a child, bring that over here, clean up your toys, put that away, it's like who even paid attention to any of those expressions? Like, whatever. But if you say Johnny, and then your kid says what, or looks at you, or yes, and then you say it's time to put your toys away, then at least you have their attention, right? Because like the processing of how we process input information, incoming information, is that we know like certain things will get our attention, and certain things don't have the pathways that we've created to be interesting. Like if you say, hey, there's ice cream, they might hear that because ice cream is kind of one of those words that is going to have an association in the emotional part of their brain that's associated to our sound. There's all these connections. So try to get their attention. We talked about trying to manage the environment. I have an extra E in environment. Okay. We want to try and do this thing called shared attention as much as possible with young children. Like reading a book together is a great example of shared attention. We're both paying attention to the same thing. And here I would just like to make my little point that in our device-filled world, it's many times the parent, and I'm speaking for myself, it's the parent that is not paying attention, that has like a half an eye on a Facebook page or a Twitter page or your email or your phone, that's constantly buzzing and dinging and ringing. And we have to like make time for and intentionally have moments where we are shared attention on something. Like let's all look at the leaves while we walk outside and talk about what color they are, and talk about how high they are on the tree or where they are on the floor. These are opportunities for language building and shared attention and bonding. So all these things are connected to each other. Here we want to repeat words or phrases. Sometimes when someone didn't hear us, then it can be frustrating to have to repeat yourself. But it's important that you do that, because especially if a child has a bit of a hearing loss or muffled speech because of the fluid, when you repeat it, but the second time they have more attention, they now got it twice. And they're starting to fill in, oh, the first time I heard only this and this, and then you said it again and I filled in what I missed. That exercise in repeating can help them then later on be better at filling in what they missed. So repeating is a good idea. However, other times you actually do want to rephrase and say it differently, because maybe the thing that they missed is because they can't quite make out that one sound, like the SH or the CH, that's too high frequency because of the kind of loss that they have. Or maybe it's a word that they're just not familiar with yet, that's not in their vocabulary. So it could be that rephrasing and saying it in a different way gets their communication effectively better. Okay, and then lastly, we talked about in the classroom, and now just broaden that to learning environment, whatever it looks like in your home or elsewhere, which is to try and do preferential seating. Okay, so close to the speaker, close to the teacher, not with things in the way, like things blocking between you and what you're trying to listen to or understand. And if there's a better ear, to face the better ear. Again, one of these stories that sticks out is of a couple, an elderly couple, that one of them had hearing loss in one ear and would always say that around the table they couldn't hear the spouse. I'm just imagining them. They were the sweetest little couple, you know, like bickering all the time with each other every time they came into the clinic. And we just like talked to them about, if your better ear is this one, then like you need to switch places, because they explained the layout of their kitchenette. And they're like, no, we're not switching places. We've been sitting in these places for 30 years. And all my books are here. And she likes being close to the stove. And no, we're not switching places. So we're like, well, okay, if you're not going to manage your environment, then I guess you're going to face the consequences. And you're going to have to turn your head instead of having it easier. Yeah, I like to share my funny stories. Hope you appreciate that. All right, the FM system is something that can be used in person classroom with big groups or even small groups, or even at home, which is basically a remote microphone system where the teacher, the speaker, will have a microphone put to their shirt or on a string like a lanyard, and that will directly stream the sound from the microphone into a device that the child would then put in their ear, or if they have hearing aids, connect into their hearing aids. And this is very effective for limiting noise when you're in background. So again, restaurant or even a playground with lots and lots of kids where it's very loud, any of this kind of FM system, remote technology can help in those situations. And that, isn't something that's typically offered to any child with middle ear effusion or otitis media, but you see, it's one of those things that might really be very helpful and beneficial to children with hearing loss, no matter what kind of hearing loss they have. Okay, so I've been talking for a long time, and I am so grateful that you came and joined me today. Before we go, I would like to invite you and introduce you to a new series that I am just launching. This is something new, so it's kind of in beta, and if you are interested in joining it with me and creating it together, I think it will be an incredible resource for all the people who will come in and join us for future programs. And so this is a program I'm calling Hearing from Both Sides, which is kind of a joke on 2 ears, but also the both sides that I'm really passionate about is this parents and professional collaboration that's outside the clinic, right? Because if you're in the doctor's office with your kid, this is a high stress situation. You have a child that you need to care for, you need to know what to do. That's not the time to start talking about effective communication with your clinician. You need to get what you need to get, and that's incredibly important, and learning how to advocate and get the language that you need to be able to push for what's important to you. All of that I think is really important, and doesn't really get, where are you supposed to learn that and practice that and process the difficult and uncomfortable situations. So that's on the parent side. And on the professional side, I feel like there's somewhat of a bubble. We have our associations and our journals and our conferences, and it's kind of like all of us talking one to another, which is excellent for when we need to learn and practice and do research and all of that. But in the space of, well, how do I say to a parent the news of something that's going to affect them a lot? Like, is there enough training or information that's not up here and in books and in research, but in the front to one, human to human, like this is another person and I don't know necessarily if I'm saying it right or saying the right thing. So especially for the young professionals, I would work a lot with students from around the world in the audiology office hours that I have monthly. So we've talked about these things a lot. And I think that it's, I've been doing parent stuff, I've been doing professional stuff, and it's time to bring us all in the room together, in the Zoom room. So I'm curious how that lands for you, how you think about something like this that I think is incredibly unique, that I haven't seen being done outside of, like, it's not a university course and it's not an advocacy training, but it's really just like for all of us to come and learn from each other. I'd love to hear your thoughts about that. And it's because this is my biggest belief, is that clinicians are experts in their fields, and we study for many years to become clinicians, whether that's audiologists, SLPs, physicians, definitely learn a lot. And we all learn also how to learn how to process all the new research that's coming and how to implement it in a way that it actually will make a difference for our patients and for our students and educators as well. But parents are experts in their child. And that, I'm also a parent, so I kind of am both of these things. And a lot of us, many of us are, where we feel this sense of a disconnect from our clinicians when they're also people, whether or not they're parents. But there's, a very human element to what goes on when you're in a 15-minute appointment, if you're lucky, in the way that a lot of healthcare is given, and there isn't necessarily the space to process and to understand both sides. So Hearing from Both Sides is going to be a three Zoom meetings that will be interactive discussion on these dates. And in order to join, you can sign up here at allaboutaudiology.com/both-sides. And there's going to be a lot of resources, like all sorts of checklists and worksheets and facilitated discussions that we're going to be having. So I am really, really excited to just be launching this at, you know, a beta price of $97 for all 3 sessions, just one payment, that I think will bring us to a much bigger understanding of what it's like. And this is open to not only parents whose children have hearing loss. You know, this is open to anybody who's interested in doing this kind of dialogue, whether there's autism or learning difficulties or anything that, you know, you've had to interact in a meaningful way with pediatricians and specialists and SLPs and audiologists and OTs and PTs and social workers and the whole team. So if you're any of those things on the clinician side, on the parent side, you are so welcome. And I think it's going to be a very special program. So that's all I have for you today. I'm very, very excited and grateful that you have signed up, that you have joined us today. For those of you watching in the replay, thank you for watching. And I'm open to any of your questions. You can always email me or find me on Instagram, on Facebook, and an email as well, now that you have my email. Yes, Ellie, please. I see you have a question.
No, I'm still overwhelmed by
Oh, no,
all the
I can't hear you.
information.
1 second. Say that again. How come I can't hear you? Is it me? Hold on. Hold on. This is a little embarrassing. I know why I can. I should hear you now. Say something else.
Do you hear me?
Yes. Okay, go.
I want to say thank you for a lovely conversation. Can we call it conversation? A slideshow.
Yes.
Was very, very informative and interesting. And it happens to me very, very rarely that I listen speechless. I was speechless during the last hour and a half. So thank you very much. The truth is that I've waited patiently and you answered everything. So I don't have questions.
Oh, yay. That's the best feeling in the world. As I always say, wait till I get to it and I'll answer your questions. Thank you so much, Yali. I appreciate that very much. And that, you know, what you said about a conversation, that's exactly what this is going to be. It's really something that I've been percolating for so long, you know, what it's going to be to be able to help all of the people in our audience. And again, for those of you who missed the beginning, the All About Audiology podcast is also where you can hear lots and lots of these kinds of conversations where I interview parents about their journey and their experience, and interview a lot of professionals about their expertise and their experience, you know, getting to that expertise and dealing with the things that we deal with. So you can definitely check out the podcast and be in touch. Anyone else? Any last questions? It's already 9:30, so I don't want to keep anyone. You all, thank you for listening. I guess that's it. We'll be in touch. I'll be emailing out the replay and more of the resources here. Thank you, Marlia, and thank you, Miriam. Thank you so much. Have a wonderful day. Oh, and you know what the coolest thing I forgot to tell you was that people from 10 different countries signed up to this lecture. That is super cool. From the US, from Kenya, from Nigeria, from Malaysia, the Philippines, Turkey, Canada, and India, and Israel. So I thought that was pretty incredible how we had people from all over the world sign up. And thank you so much for being part of the All About Audiology community. Take care. Bye.